I think now I would like to invite Dr. Tarek Al-Said up to lead us in a question and answer session. Dr. Al-Said is one of our brilliant core imagers here at Pittsburgh. He does exceptional echo, cardiac MR, and cardiac CT imaging. So thanks, Tarek.
Thank you very much. Thank you very much, Laura, and thank you very much, Jackie and Libby. This was such an incredible session, really great talks. So we have few questions coming through the chat. So one question from Dr. Arapa was asking Dr. Weinberg, what are some of the measures that you can do to prevent prematurity in this population?
Sure. So when we diagnose significant congenital heart disease, and especially with these functionally univentricular hearts, that is always the question about when is optimal timing for delivery and how we sort of optimize that and try to avoid prematurity. We know that for these babies, adding in prematurity and the differences that we have in their lung development and their brain development significantly, that those are all challenges in the long term, both for the initial surgical palliations, but also in their long-term prognosis. So we know from a lot of data that's out there that avoiding prematurity is best for these babies, and that is often a challenge because when the obstetricians know that there's a fetal issue, that can make things harder to monitor during the pregnancy and makes them more nervous too. We understand, but we work really closely with our MFM colleagues, our high-risk obstetricians, and this question very frequently does come up. We often are discussing the babies as far as what optimal monitoring strategies are, whether it's monitoring of fetal heart rates with NSTs, monitoring of fetal well-being with ultrasound assessment from their standpoint as well. And we encourage them to not deliver prior to 39 weeks gestation when at all possible. Of course, that has to be sort of countered by assessments, making sure that the baby is growing in the intrauterine environment. Intrauterine growth restriction can be a big problem. We know it's more common with congenital heart lesions, especially severe ones like our univentricular hearts. And in a lot of times there is question about whether that fetal placental environment is worse for the baby than having them in the outside world. And so it's usually a very intimate, close relationship with us and the MFMs and lots of discussion, but trying to encourage them to deliver later and avoiding use of just the growth parameters, but looking at the overall fetal well-being before deciding when to deliver. So it takes a lot of communication.
Thank you, Dr. Weinberg. I have another question from Dr. Tan to Dr. Lamford. For functionally univentricular heart, what echo parameters do you prefer to assess function in these patients?
Oh, that's a challenge. Depends on which ventricle we're talking about. The LV, we still use standard LV measures. Although I think as we saw, the LV does tend to be dilated when it's the dominant left ventricle. So for that, we still, if you can get a good short axis, you can do a shortening fraction and then the apical four chamber. And we also use bullet method sometimes since there are normals for pediatrics, we use the bullet method if you can get a good parasternal short axis. RV is a challenge. So a lot of qualitative. We do measure TAPSE, RV fractional area change. I try in my head, and 3D will help us with this, certainly, put together the images from an apical 4. I think you get the TAPSE and the RV fractional area change, but then the question is the RVOT. So in my head, I sort of try to add them up. If one looks down and the other looks good, then you might get a mild RV dysfunction, but it's very difficult to be truly quantitative in a single dominant RVs. I echo.
Excellent.
We get MRIs when they're older.
Excellent. Thank you, Dr. Lamford. Speaking of MRIs to evaluate ventricular size and function, there is a question from Dr. Natarajan about ventricular volumes or other indices in borderline left ventricle and how you use that.
That's a great question, and it's a question that, so The answer is that there is, I think every year that goes by, there's more and more evidence to suggest that cardiac MR is exceptionally useful in answering this question. The group in Toronto, the group in Boston, and other groups around specifically have published on this. And it's really interesting, every time a publication comes out, and I know you know this, Tarek, too, it seems like the threshold for what is considered an acceptable LV seems to keep creeping down. I think it started somewhere in the 50s. I think it's in the 30s now, based on the different institutional experiences. But I think the upshot here is that cardiac MR is a tool that can be helpful in this case. It is very important that the cardiac MR is performed and interpreted by a lab that's comfortable doing this and takes all of the little, manages all the little details of the acquisition appropriately in order to get the best data out of it. But the upshot is that yes, cardiac MR can be very helpful to answer that question.
Thank you.
Still need to evaluate the valves. So just, which is best done with echo. So just in terms of size, yes, MR.
Do you want to address the issue of EFE? Because sometimes you can have a normal LV volume,
Yeah.
but in the example that I showed, I think that there was probably much more EFE than we realized by echo and severe LV diastolic dysfunction.
Yeah, so that's another great, and I just have to recommend to anyone listening that I think I'm trying to remember the first authors' names, but they've done beautiful. There'd be a few from Toronto that have really tackled this exceptionally in an exceptional and systematic way. So for sure, EFE on echo, the corollary on MR is late enhancement. So for sure, like extensive late enhancement, even with a normal-ish LV volume, yeah, that's not going to be a successful 2V strategy. And same thing for an LV volume that's normal, but the mitral valve is like thick with shortened chordae and a huge, inflow gradient. That might not be successful either. So to your point, yeah, the fibrosis matters. I don't know that anyone knows precisely how much fibrosis is enough or is tolerable. I think those questions are still out there and they're exceptionally hard to answer because fibrosis seems to be like a binary, it's either like present or absent. Rather than being quantitative in these little babies at this point. But your point is well made.
Thank you. Another question about like prenatal counseling for these families. So a lot of times these single ventricle patients can have a lot of other medical problems and can have very complex anatomy. So at what point would you start talking more about like, palliative care or like that intervention may not, improve the quality of life or the duration of life for these patients?
Yeah, that's a really important question. I think that the short answer is that we could always be talking about that more. And I think that any fetus that we're counseling a family about a functional univentricular heart who we expect to require surgical staged palliation rather than any possibility of a two ventricular repair, we know that that course is going to be long and that there's going to be complications. And we also know that some of those cases are more straightforward. In some of the examples that we showed today, both prenatally and postnatally, there are times when that's more straightforward and there's times when it's less straightforward and more complex. The patient that we all showed examples of that has complex venous anatomy is one example where surgical palliation we expect to be more complicated. The other fetal patient that I showed that had poor right ventricular function, we would also expect may have a more rocky course than others. And so those are in particular the cases that we more strongly than others recommend a prenatal consultation with our palliative care, we call it supportive care team here. And they actually can start to introduce those ideas with us to the family about both understanding what the course will look like, what the complications may be down the line, should they go through with a surgical palliation, but in some cases, we do try and bring up the option of comfort care with all of these patients. But again, in some, it's more of a focus of our conversation than others. In a lot of places, we know that we can perform surgical palliation for these babies, but it is recognized that that does not create a two ventricular circulation, and that I do express to families that will have long-term consequences and limitations. And so helping families understand the situation and the expected course is the first step. And I think it is important to offer them options, which can include comfort measures without surgical palliation in some cases. It's a tricky conversation to have sometimes, but I think it's important for sure.
Fantastic. Thank you very much. I think we all agree this was a fantastic session, so let's give the speakers another round of applause.